Well, good afternoon. We're thrilled to be at the Texas Biomedical Research Institute's Global Health Symposium 2023. We're thankful to the organizers for the invitations. Today we have a great topic to discuss, decolonizing global health. What should be the target of the movement and where does it lead us? Well, tackling this topic is a distinguished group of scholars, administrators, and practitioners. We begin with Dr. Wanda Anyako, who's here with us. She's a physician executive, speaker, coach, and consultant based in Seattle, Washington, a board-certified pediatrician. Dr. Anyako serves as Vice President and Chief Health Equity Officer for Providence Swedish Health Services. Working closely with clinical and community leaders, she leads efforts in advancing equity in healthcare and the delivery of culturally competent care, with an emphasis on technology and digital innovation. She's an experienced executive and physician leader with expertise in clinical and business decision-making. Dr. Anyako is faculty at Carnegie Mellon University Master of Medical Management program. As a strategic advisor and consultant, she not only specializes in health equity, but also provides leadership development and supports physicians and executives in every aspect of their leadership journeys, including career reimagining and strategic planning. Welcome, Dr. Anyako. Next, we have our virtual panelists, Dr. Kechi Achebe. Kechi is the Director of Global Health and HIV for Peace Corps. She's an experienced public health physician, scientist, and researcher with more than 20 years of technical, programmatic, and leadership experience in public health and clinical medicine. A recognized global expert in the areas of global health, especially HIV, AIDS, and tuberculosis. She has worked and led the design and delivery of public health programs globally. Welcome, Dr. Achebe. Next, we have Tracy Baird. She's the president and CEO of Engender Health. Tracy is an experienced leader in the field of sexual and reproductive health and rights and has led Engender Health since October 2018. Her subject matter expertise and leadership experience were honed through 22 years at IPAS, a global nonprofit, and as CEO of Shift North Carolina, a statewide nonprofit in North Carolina. Tracy recently catalyzed an initiative to transform international NGOs' operating models to engage more equitably in global health. Next is Dr. Christy Mikas, who's a senior global health advisor, Centers for Disease Control and Prevention. Dr. Mikas leads the Centers for Disease CDC's Washington team to advance global health priorities through direct engagement with stakeholders across the U.S. government, external partners, and with multilateral partners. And last, I'm the moderator, Dr. Achebe. I'm the chairman and CEO of African Integrated Development Enterprise, PBC. Essentially what we do is raise funds to match African projects, particularly in healthcare, renewable energy, as well as in education. We're going to begin. I'm going to provide context. So I'm going to give a little introduction. I think this topic is a little large in size, so let's try and summarize the few key points. The term global health is defined by various scholars, such as Kickbush, McFarlane, Copeland, and Chen, as an area that focuses on health issues with a global concern and with the goal of promoting global health equity. The authors pinpoint 4 historical periods of global health. The colonial era, which we know about, which was deeply rooted in the desire by medical experts from the former colonial powers to understand the disease, etiology, patterns, treatment of indigenous populations living in the so-called global south, which was subsequently given the term tropical medicine. Then there's the post-World War II era, a period of global health practices and research called international health. This kind of stayed with us till today. That focused on the cooperation and exchange of resources and power among sovereign nations based on their respective needs. From there, we got the term Official Development Assistance, ODA, which flowed from former colonizers to former colonized countries for the latter's development. Similar resources were also used by the United States, as well as the Soviet Union, to attract countries to join their respective blocs during the Cold War. Third, we had the era of structural adjustment programs. This was instituted by the World Bank and the International Monetary Fund beginning in the 1970s. During this period, donor agencies set very strict, I think, draconian conditions for countries in crisis to borrow money for economic recovery. Those measures often included cutting public budgets, such as salaries for doctors and teachers. There were dire consequences of SAP, as it came to be known. Economies of recipient countries reeled. There was a net brain drain of top young talent in the health sector out of low and middle income countries to high income countries. SAP weakened the health systems of recipient countries. Some collapsed, retarding economic growth for generations. Now, detractors characterize this era as one that perpetuated the unjust systems facing former colonized countries. Now, many nations in the global south would do well to better control corruption, improve governance, and strengthen democratic institutions within their sovereign borders. So this is not just about donor countries. The recipient countries need to look internally at what they're doing. These internal modifications will propel them to great prosperity on their own terms and strengthen their bargaining positions at the table of global power talks. Now, in the 21st century, global health has been framed as a call for equity and justice. However, the colonial remnants are still very much there, and it could be argued that more often than not, global health is old wine in new bottles. So Dr. Anyako, I'm going to turn to you, having provided this background. Today, we need to recognize the persistence of the legacies from the colonial era. How would you define decolonization of global health?
Thank you for having me. Hello, everyone. And as we explore this really complex topic, I think it's really important that we are intentional about having these conversations. Decolonization of global health really talks about undoing the vestiges of colonialism. When we talk about the quest for health equity, it's really important to understand that a lot of the inequity is a function of historical structural racism, colonialism, whether it's occurring on these shores or in the global playing field. And so we have to think about how we engage with the communities that we are trying to serve, the indigenous communities in all of those different locations across the world. Understanding, a way to lift their voice, bring their knowledge into play in how we determine what is best for healthcare in those societies. So there's a lot of conversation about indigenous communities need to be at the table. They need to be more than at the table. They need to be integrated in what is considered knowledge. What are those tables discussions based on? So way beyond being at the table, they need to be an integral part of how we strategize to address global health issues.
Thank you. Thank you, Dr. Anyako. Let's remain with you. How can we effectively tackle these colonial remnants of global health?
I'll go back a bit to the definitions of the different phases of global health, right? So the colonial era, which talked about understanding the indigenous illnesses. Really, the reason for that was that the colonial powers wanted to understand how those illnesses impacted them. It really wasn't about those communities. And so if you start to think about how we unravel, we first have to understand how those structures came into being in the very first place. So changing practices, and so if you think about building a health system based on the colonial powers versus the indigenous powers, you've already built a disparity into the way that you gather data. So we must change those practices. We must change the power dynamic. That's the first thing we need to do. And the way to do that is to bring the players to the table. We also need to restructure the tenets of the financial, structures that have put us in this challenging space. So we talk about the age of structural adjustment program and how difficult that was for those communities, because whoever was designing it probably didn't take the time to sit in the shoes of those communities that you were designing these structural adjustment programs for. Because, people often think of themselves as benefactors and they're trying to do the right thing. But when you look back at the wake and the impact of those decisions, you see that it really created a lot of harm. And so we agree that those communities need to look inward and address corruption. But that oversimplifies just how difficult it is for those communities to get access to finance, right? They get funding at higher interest rates. It's harder for them to do the things that they need to do. And so we all have to look at it simultaneously and look at different ways to address those disparities. We also have to look at pervasive views of communities that really tend to be based on white supremacist or racist structures that say that others are not as good, right? So the way that we do things, or the way the wisdom of our traditional communities are not given the same honor as the more Western ways of treating, of approaching healthcare. And so to start to unravel health inequity, you have to actually acknowledge that there should be nothing about me without me. And that there is power in our history and our cultures, and all of that should be part of the planning for what is supposed to be a better future, Global Health 4.0, hopefully. Finally, I'd say there's concern about neocolonialism from the influence from new entries into the global health space, and most people talk about China. And I would argue that it's not neocolonialism, it's just different players. Different tools, different players. And so we need to be aware that if we are not intentional and at the table, we're going to replicate the same things that the previous colonial powers did. And that doesn't make China, doesn't let them off the hook, but it doesn't make them any different from anybody who has gone before. And as we start looking at digital health, machine learning, AI, it is desperately important that the voice of indigenous communities around the world, their numbers, their data are part of that machine learning. Because if you think there's inequity now, when you build it into a machine that's going to exponentially increase those disparities if we're not intentional in building equity in by design. So, just a few things.
Thank you very much, Dr. Anyako. I'm going to move on to Dr. Christy Mikasashi up. Hi, Christy.
I'm here.
Great.
Hi, how are you?
We're excellent. So Dr. Anyako has laid out the definition of the strategies for decolonization of global health. You work for a globally respected, influential, and powerful organization. Please tell us, how does the CDC ensure that principles of health equity, decolonization, and human rights are embedded in the CDC's activities, whether at the headquarters or at the country level?
Great. Thank you so much, Dr. Achebe. And it's wonderful to be here with all of you today. To better understand our global health work at CDC, it's important to first understand the broader context. And that is that CDC serves as the nation's premier health protection agency, working 24/7 to protect America from health and safety threats. That said, from a global health perspective, domestic and international health are inseparable, and we know that no one country can safeguard the health of its citizens in isolation from the rest of the world. So we have staff on the ground around the world with country and regional offices in more than 60 countries, forming a unique peer-to-peer global network of foreign, multilateral, and external partners. And in these countries, CDC works very closely with ministries of health and local partners to build capacity in surveillance, laboratory, emergency response, and the public health workforce needed to respond to disease outbreaks and also to prepare for future threats. And so we're constantly adapting and innovating to meet new global health challenges such as COVID-19, enhancing global health security, and making measurable progress on perennial global health issues such as HIV, TB, immunization, malaria, influenza, antimicrobial resistance, and so many other global concerns. And so our efforts are having real impact, including reducing disparities and advancing our global health equity goals. So in our organization at CDC, we believe that working with partners is paramount to achieving sustainable health equity. It's critical to find common ground with and improve equity among public health professionals who serve the most affected populations, especially local partners. And I'm also happy to say that CDC has renewed its efforts in the past several years to ensure that the principles of health equity and decolonization are embedded in our global work. Last year, CDC launched an agency-wide strategy that aims to integrate health equity into everything that we do. And as outlined in this strategy, CDC is committed to cultivating comprehensive health equity science, optimizing interventions, reinforcing and expanding robust partnerships, and enhancing capacity and workforce engagement. So this commitment ensures that health equity and the elimination of health inequities remains central to CDC's work and holistically transforms the agency's approach to public health. This strategy also builds upon a human rights-based approach to specifically address availability, accessibility, acceptability, and quality of our global health programs. It acknowledges that the right to health can be pursued by numerous and complementary approaches. Specific programmatic and cross-cutting goals in CDC's global health equity strategy also help countries that we work with eliminate health disparities and highlight determinants of health that negatively impact historically, socially, or geographically excluded or other marginalized groups. So I have many examples of this, but I'll turn it back to you, Dr. Achebe, so I don't go over time.
Well, let's stay with you, Christy. So you work in Washington now, but you spent about 11 years in Zambia. You were leading the PEPFAR program there. Did you notice any improvements in the way the U.S. government tailored its public health solutions in that country and to other subpopulations within the country? Can you help us understand how they tackled this conundrum?
Yes, absolutely. I was working with the PEPFAR program from 2003 when PEPFAR was first launched until 2019, and then conducted research as part of my doctoral program on impacted populations, pediatric HIV case finding in particular. But I've really had a front row seat to see the changes along the way and how PEPFAR has been operationalized and implemented. In the early days of PEPFAR, there was an incredible focus on getting financial resources out as quickly as possible. It was an emergency response, after all. But over the years, as we worked in many countries, capacity was built in ministries of health and in other organizations. And there was recognition that we needed to work with partners in a more sustainable way. So then we began working to deliberately provide direct financing to local organizations and entities for service deliveries. And that's very important. There was a local partners initiative, and a lot of effort went also to ensuring that local organizations had financial systems and other supports in place to receive direct funding from the U.S. government. CDC is a strong supporter of local indigenous organizations. Just really want to echo what our previous speaker was mentioning as well. When I left Zambia in 2019, approximately 75% of CDC's resources in Zambia were going to local organizations, including the government of Zambia. And there's really just no substitute for having that direct financial support. But it wasn't just financial in terms of how we evolved our way of working to a more equitable and inclusive approach. Even the way that we implemented programs became more equitable. In the early days of PEPFAR, there was so much pressure to achieve results and quickly demonstrate success in expanding prevention, care, and treatment programs. It's my view that in the early days of PEPFAR, we implemented for results, whereas in later years, we implemented for results while building capacity. Capacity of our implementing partners, laboratories, National Public Health Institutes, field epidemiologists, and other healthcare workers. Working in a way where you can leverage those capacities that have been built, utilizing local organizations, systems, and people, and of course the programs that now can achieve so much more that capacity has been built. I've also seen a major difference in how we plan and evaluate our programs. And anyone who works in PEPFAR is familiar with the country operational plan, or COP process. Love it or hate it. It used to be that there were teams of U.S. government interagency colleagues who would meet to plan the next year's activities and then work to bring other partners in. And over the years, other partners, including local partners and civil society partners, began to join the planning process earlier and earlier in the process until ultimately they were brought in from day one, or even before day one, as PEPFAR also began to bring in partners on a quarterly basis to review progress of ongoing programs. So these shifts in how the program operated provided greater access to decision makers, afforded better utilization of resources, and ultimately led to stronger programs. There is still much more to be done, but this progression is certainly encouraging.
Thank you, Christy. This is a perfect segue to Tracy. Hi, Tracy. How are you?
Hi.
Great. You work and lead an international NGO. INGOs have a very interesting role in global health. They tend to be extremely well resourced. They have the ear of the donors. Please tell us how Engender Health is thinking about and involved in the movement to decolonize global health.
Yes, thanks. And it's just so great to be part of this panel because we really do have an arc in this conversation. I'd say, our efforts right now are in two categories. One is internally and also in terms of how we're engaged more in the world. Internally, we see our efforts to decolonize global health and support locally led leadership by how we value local leadership of our teams, how we're shifting different roles to countries and different international settings, hiring national staff of the countries and of the systems where we're working, and our sincere engagement with local partners, which has really evolved so that we are working with our local partners more mutually, sometimes with them leading, sometimes with us providing support, but really based on what the needs are and based on how we can build advantage for each other. And I had a great example of our shifts in this internal process just earlier this week. We have a colleague leading one of our country programs who the program closed for a few years due to funding. When it reopened, we rehired a leader who had been with us. And he said after 3 years at Engender Health, he feels like he's racing to catch up with a moving train because we've changed so much, particularly in how country programs are really leading and guiding our country work. And I was pleased and proud to hear that, not pleased he's racing to catch the train, but pleased that it's showing up in the way that we're truly engaging internally and with our immediate partners, and how we're shifting roles and responsibilities and ultimately power. We're also really engaged in this in the environment around us. We know and we've been really learning a lot about what local organizations and regional movements and organizations want from international NGOs. And our interest is really in moving the sector together. We can't decide how INGOs should behave in the future. We can't just use our good intentions as a shield for designing our future and roles. That's the process that got us here, and it's not good enough going forward. We really need it to be collaborative, and the way we co-design projects and previous panelists have talked about that co-design from the first day. We need to co-design the sector, and not just the project or the work at a country level, but really how the entire field is behaving. And I think the outcome is that, as we decolonize or as we are anti-colonialist, it really does involve rearranging power and shifting decision-making roles and resources and recognition. And we have to be okay with this. I know personally that as an advocate for this, I might be giving something up. I may not personally have the same opportunities in the future because those opportunities really should belong to someone else somewhere else. And same with Engender Health and any other international organization, especially those based in countries like the US or Western Northern Europe that have held the power because we designed the system with our power. So I think we have to be a bit uncomfortable so things can be equitably distributed in the future. And what we are hearing, though, from our scoping and conversations with local and indigenous organizations is that they still want international NGOs to exist. There's a future. It just needs to be an equitable one. So it's not about shifting and erasure. It's really about redesigning our entire engagement across the sector.
Fantastic. Just staying with you, tell us what mistakes you think have been made in global health as we work to address some of these problems and decolonize the sector.
Yes, and actually, I think, Christy, you set me up so well for this question because I think some of your examples from PEPFAR are ones that I see not as mistakes, but as things that pointed to the mistakes we had made. Recently, as part of PEPFAR, is the Presidential Emergency Plan for AIDS Relief that was launched by President George W. Bush 20 years ago, and in 20 years, that program and that funding have saved 25 million lives. So we have a lot to learn. We must learn from the impact of that program, right? We should, let's really capture what we can gain and understand from it. And at one of the recent 20th anniversary events, some advocates were saying, the community, the HIV/AIDS community came to parts of East and Southern Africa years ago and said, well, Africans can't take medication the same time every day. This won't work. People won't get tested because people won't get tested. We will not be able to address the needs of men who have sex with men because of the cultures in these places. I think the answer is we underestimate people, right? I think that's one of the key problems we've made in global health. I think PEPFAR gives us some very specific examples of how we have underestimated people and how people the world over will surprise us if given the chance to have agency and input and power and control of their health. So I think one of the challenges in global health is to overcome the error that I believe we've probably made innumerable times in underestimating individuals, communities, and systems because we weren't of them. We didn't understand them. This is there's a we here that did the underestimating and the people who were underestimated that really need that power. And I think we're also really siloed in a lot of ways. We think we can solve problems in a conference room. And again, the example of PEPFAR of, not just getting input to a draft, but designing from day one or being part of the process to design how to design. I think that is going to be the way of the future. And honestly, one of our challenges is our donors are still doing that design ahead of time. They want us to co-design a project in response to their request for proposals that's already been kind of pre-designed without necessarily the level of community input that could make the biggest difference. So we have a few challenges to overcome, and fortunately, some good examples to help us do that.
So in the interest of time, can you let us, I don't want to miss this. This is a very important aspect of the discussion, and that's gender. And that's one of the really powerful pillars of Engender Health. Tell me how the themes of gender are part of this conversation about decolonizing global health. Briefly, please.
Yeah, we know that 70% of the global health workforce is female. Half the world's population is female, yet only 30% of leadership in global health is female. We heard earlier that we need to do more than give people a seat at the table. And it's the same thing with gender. Women need more than a seat at the table. Women need power and decision making. When women are healthy, they'll take care of their families and communities. And we need to make sure that our entire systems are recognizing the inequities in gender that start at the community level, right? They start in our own childhoods for every one of us in terms of how we perceive and understand gender. And they go through and influence everything up to, parliamentary power dynamics. So we can't move forward without unpacking the issues around gender and gender equality, or we're leaving 50% of our brain power on the table, and we're not fully utilizing the human capacity we have to solve the problems we need to solve.
Thank you very much. We're going to move to Dr. Kechi Achebe. There she is. If you're wondering whether we're related, we are. Tracy has highlighted the frustrations and failures within the systems and outlined some strategies to work between donor and recipient organizations more effectively. Let me begin by asking a two-pronged question to you. What strengths do organizations bring in negotiation? And two, how are we able to say we individualize what we're doing while avoiding a cookie-cutter process? Dr. Achebe?
Thank you so much, Dr. Chebe. And, it's nice to be with everyone here. I think I'll take your question also in a two-pronged response scheme. And the first one, where your question on what strengths do organizations bring? I think we have to look at the two organizations. Everyone here has talked about the donors and then the local organizations. And I'm really going to focus more on the local, because Tracy just talked about the donor and what the donor brings. The local organization, they bring the power of understanding the local context. Dr. Anyoku started with the slogan, "Nothing for us without us." They do know what they need. And, the sooner that we use and understand that without involving those local entities, and I want to call them local stakeholders, because it's not just the local organization, it's the governments, it's the local municipalities, is the priority groups that we're supporting, the women that Tracy has talked about, the women's group, and all the stakeholders. We really have to understand that they do have the solution to their own problem. And the sooner that we bring them into that conversation, the easier and more effective the solution is going to be. And, when we talk about how do we individualize what we're doing, I look at, Christy mentioned PEPFAR and the shift that PEPFAR has had in the 20 years. Indeed, yeah, PEPFAR started as as an emergency response, because at that point, you go into countries, Zambia, South Africa, 1 in 4 people you speak to was HIV positive. 1 in 5 people, had a CD4 count that needed them to be on ARVs. And now we're in a phase where, PEPFAR has been very effective. Lots of countries have got to the 95 global targets. And so we now really we are now in the phase of sustainability. And when we're looking at sustainability, if you look at PEPFAR's new 5-year strategy, it's really talking about shifting the dynamic. We all have to work ourselves out of a job. There are lots of, global health issues. This pandemic has taught us that, there are going to be, and with global warming and climate change, there are going to be new emerging diseases. So there are things that we need to focus on, but we do need to ensure what we have learned of 20 years of PEPFAR is that we really need to move to a sustainability response where we work hand in hand. And it's not just about giving local organizations the same amount of funding, but to Tracy's point, you really need to bring them to the table. And that is what PEPFAR has done, to say, okay, what is the issue and how can we work on that issue together? Because when you bring them in later on, then it's going to be almost like walking from, you already have an answer. So that's where PEPFAR's new, PEPFAR Reimagined strategy that was just released in December 2022 has moved to. But the agency I work with, also U.S. government agency, Peace Corps, that's really the DNA of Peace Corps. Peace Corps goes and we work with the local groups, we design with the local groups. The Peace Corps volunteers who are U.S. citizens go to live, eat, and really get embedded in those communities. And no one works without a local counterpart, and the local counterpart really drives what the volunteers to do. So indeed, I'll just say that we need to make sure that in everything that we do, that we have the community take ownership, because they know, if you come to my house, if I go into your house, I know what you want to eat, and it doesn't matter if you give me the nicest looking meal. If that's not what I want to eat, then, you're not going to stop me from being hungry. So that is also the way that we have to walk. We have to know that in negotiation, we have to be open, we have to be flexible, we have to ensure there's community ownership, and we have to make sure that we are listening. We're doing more listening than we're creating the solutions. And we really also need to look at the foundational issues. How is the health systems? It doesn't matter how much you pump money. If the health system is fragile, it's non-existent, what you build, you're just going to be building, it's going to be like you're building on top of a pack of cards, and everything is going to fall down with time. So being foundational, being intentional, being strategic is really important.
Thank you. This is a recurring theme that is really important, and that's gender and how women need to be pulled into this entire process of leadership and decolonization. I'm going to also add youth. Can you speak to your organization's work in pulling young people and women into this movement?
Sure, definitely. At Peace Corps, we're working all over the globe, and 80% of our target population are youth, and and also women. Women, as one of my earlier speakers mentioned, they're really the bedrock of the community, and if we don't pull them in to help us create. I don't even call it co-create. They have to be the ones to create the solutions. We spend a lot of time, and it's not the most efficient way. So Peace Corps has, and many other agencies have observed this, and there's lots of studies and research that shows that it is important. We all know we're also living in a time of the youth bulge. Many countries is very the population is more youth. Most countries, their population is half of their population is under the age of 50, and even in some it's 40 years. So if we're not working with the youth, then we're going to miss a big part of setting up the systems. And so Peace Corps as an agency, like I mentioned earlier, we work with the youth. The focus, our priority is the youth, adolescent girls and young women, most especially. And we have them as what we call the counterparts. So lots of our volunteers are also youth. So when they go into the country, they are able to have a peer that is their counterpart that is youth, and together they work in the community, because some of us have youth for children, or for nieces and nephews, and we know how most of the times they don't talk to the adults. So you really need to ensure that if you're looking at solutions, that we're looking at the peer support system, and that is something that Peace Corps we invest a lot in. We call the youth. We have youth summits. We make sure that our programs are youth-led, and but of course, we also have to be sensitive that youths also need direction. But it's equally important that we give them a voice and we give them a seat at the table.
Thank you, Dr. Achebe. At this juncture, we're going to open it up for questions from the audience and virtually. We have time for one question, and please keep it succinct. We're running a bit behind, so please keep it succinct.
Sure. Thank you very much. My name is Iyama FM. I work for Engender Health as the Senior Global Fistula Manager for Momentum Safe Surgery projects, and we're implemented by Engender Health, actually. Yes, we've had a lot of discussions, and I thank the presenters for all they have said, and especially my president, Tracy, for the points she raised, key points, actually, which is what I'd like to to take on, my question will be directed based on that to CDC, Christy. I think that's the name, yes. When CDC started, you noted and truly that it was about numbers. You wanted results. And I remember at that time we were running like headless chicken, trying to get results for CDC to continue. But the challenge remained how the community itself saw that. How the community saw that. And that created some disenchantment within the community, and it made the community blame those with HIV/AIDS even more than they would have, because they didn't accept that. It's also what happened during the era of orphans and vulnerable children, because donors came in and they were pumping money to orphans and vulnerable children and dressing them better to go to schools and so on. Another kids started wishing that their parents were dead so that they could be like these people. And we know that within the communities in Africa specifically, there is a family structure. And when a parent in a family dies, the family members take on these children and they live together as one. Wouldn't it be ideal to begin to think about supporting families rather than supporting individuals that are ill and things and so on? Just a question.
All right. Thank you. Christy?
Great. Thank you so much for that question. Really appreciate that. And when I was talking about how we were so impact focused, really talking about the way that PEPFAR started, and the people who were providing funding to us, the U.S. Congress and the American people, really demanding those immediate results. It wasn't necessarily a preference at that time in terms of how the program was rolling out, but more so just a way that we could try to keep the tap running, because it was such a unique moment to have so many hundreds of millions of dollars for the first time to tackle a single global health issue. But you raise a really good point and a really good question. And I think what you're discussing brings more light onto the issue of why we need to involve people who we're working with, so that you don't distort some of those community incentives and some of those structures. A lot of what we do at CDC is working directly with ministries of health. And then we have other partners that are working at the community level, and of course, other interagency colleagues. And I know Dr. Kechi Echebe was just talking about some of the youth programs as well. I think this is an area where the breadth of the U.S. government approach, working with a lot of other partners, and especially local partners, is just really critical, because there's no way that one partner is going to be able to come in and address all of those needs and understand what is necessary in that context. And that specific community context and that country context is absolutely critical, because the structures and incentives that may work in one place, or the disincentives that may work in one place, may not resonate in different communities. And so in a country like Zambia, where you have 11 different provinces and there are 75 different languages spoken in the state, in a country that's similarly the size of Texas, you have a lot of local communities. And so we really need to work as a team and as partners on that, to make sure that we're addressing all of those needs. But I thank you so much for that question, and it's definitely been a passion issue of mine as well.
Thank you. We're going to squeeze in one question from online. This is from Juan Ignacio Garcia. Are there examples on how the aid financial system in infectious diseases biomedical research is changing to address issues in neo-colonialism? I think this is appropriate for either Christy or Dr. Echebe.
Well, I think it would be interesting to know a little bit more about that question, but I think I can give a good example of the work that we've done with Africa CDC, perhaps, and I think that's also been an effort that's been cross-cutting. As you may know, Africa CDC is a specialized technical institution of the AU, and they support public health initiatives of AU member states and strengthen the capacity of those public health institutions to better detect, prevent, control, and respond quickly and effectively to disease threats. initially, when we began working with Africa CDC, the relationship that we had on their ability to be able to do their work was very different than it is now. We were one of the foundational partners in 2017. And at that time, we were really helping to define systems and strategy. And now that partnership has completely evolved. And they are now a critical leader on the continent. So we've been really pleased to work with them on their surveillance and disease intelligence, as well as information systems, laboratory systems and networks, emergency preparedness and response, public health research, as well as disease control and prevention. And now that work, as that partnership has evolved and changed, that work can now go to new levels. So I think really investing in a regional organization like Africa CDC and like other partners that we work with, who can work with different countries and other member states, is not only a solid investment, but also helps advance our global health equity goals in our programming.
Okay, because of time, we're going to round up by asking each speaker to give some closing remarks. So 1 minute apiece. Let's start with Dr. Anyoko, please.
Thank you. This has been such a great conversation, and I just want to anchor it in the definition of global health by the late, great Paul Farmer. He told us that global health is not an academic exercise. It is truly the quest for health equity across the world. And when we seek health equity, we have to look at the structures that have created the inequity. And those structures are based in our colonial past and the structures and the incentives by which the health systems were created. And so, as has been shared today, we've learned that it is important that we have the voice of the communities, the indigenous communities, at the table from the start, not after you've created the idea, doing it as a patchwork. But I also want to talk about the source of knowledge. What actually defines knowledge, and how do we decide what is true and what is right? So, for example, in science, we describe randomized controlled studies as a gold standard. Well, if you're dealing with a community that is based on oral history, that's a whole body of knowledge that can never be included in that science. So how do we think about that as we work towards the new form of global health? And finally, we as the communities that are being helped have to look at internalized colonialism. Because the structures have been built that way, we've also come to believe that the Western way is the right way. And so as we look internally at our structures, we also have to look internally at our beliefs and how we engage with our global partners in quest for global health equity.
Thank you, Dr. Anyoko. Christy?
Thank you so much. I really appreciate so many of the comments that were made by the fellow panelists. Nothing for us without us. We need to be comfortable with being uncomfortable because we're talking about power. The metaphor of being served a meal, but a meal that you may not like or may not be able to eat, could be allergic to. And so much of that resonates with me as well. And I think in closing, I'd really like to highlight the importance of true partnerships and collaboration to solve mutual global health challenges. It's really one thing to work alongside partners in global health, and it's quite another to provide technical support to build capacity along the way. And in some situations and some relationships, it means that you're starting to take a back seat. And so I think that we have all sort of spoken about that, and that's the reality. So how do we then communicate that to some of our stakeholders who are still requiring to see those results? And we are showing results, but that's an important piece of achieving those results. And for us, it comes down to how we operate. And for us, that's our people who are our greatest asset. And we have locally employed staff in our country offices that make up the vast majority of our global health workforce. So I think that's a really important component. Without our local staff, we would not be able to abide by the guiding principles in our health equity work, prioritizing populations with the greatest need first, engaging affected populations, and collaborating with partners. So although we're proud of our progress and the impact and plans, we need inputs to be fully successful as we all work to advance this work through our different channels. And We welcome your feedback and look forward to continuing a dialogue with all of you here today. So I do hope you'll be in touch. And it really is the start of a very important shift in how we do our work.
Thank you, Christy. Tracy?
Thank you. I want to loop back to the issue around gender, and I'll bring in your important point about young people too. It's part of addressing root causes, right? We aren't going to change the gender balance of decision makers, for example, in the senior roles of the Ministry of Health, if we aren't first addressing the gender norms in communities and the biases against girls' education or health or well-being at very young ages. So I think we need to recognize that we can never have equity in health and a successful global health workforce and system if women aren't part of the solution. I would also say that in addition to being comfortable being uncomfortable, we need to be brave and support each other in being brave. We need to try things that maybe haven't been tried before, try things that feel risky, and we need to support each other. The global health, the whole entire global health community across the world needs to support each other in trying to do things differently and getting feedback about it. I loved Christy just said, that CDC wants input. And I think that's right. We need to not only say that we're receptive to input, we need to go out and seek it, and we need to get the bad news. I think it's so easy to say, oh, we heard some feedback and it was, reasonably good news. We need to go in search of bad news, and that's what's going to help push us forward. So I think we're going to need to be a bit courageous and mutually supportive in that process for us to make the progress that we want and must make. Thank you.
Thank you. Dr. Achebe?
Thank you. I think we've had a lot of thought-provoking information during this panel, but I'll just sum it up to a few sentences. Like I mentioned at the start, developing countries do have the solution, and we do need to recognize that they have the solution. They have the human resources, they have the expertise, and they also have the cultural context that we need to very much acknowledge and we need to appreciate. And I think that we all have seen a shift in the way we work, in the way we're very sensitive to neocolonialism as we work. But I think that we also need to recognize that anything we're doing in global health, we must wear a sustainability lens. We must look at it from a sustainability lens. And to do that, I'll still go back to that slogan, we must always recognize that there's nothing for us without us. We must recognize that the solutions are in the hands of the locals, and that their role, their inputs, and their expertise is key and integral to the solution. Thank you.
Thank you. So thank you, panelists, audience, and organizers, and online attendees. The panel has succeeded in many things. It began by defining colonialism and decolonialism of global health. It then examined colonial remnants and impediments of equitable global health funding and project execution, and came up with strategies for decolonization of global health. We learned how the CDC integrates global health equity efforts throughout its global portfolio. We highlighted the critical importance of regional work and leadership. Example, Africa CDC. We touched on international NGOs such as Engender Health and their important role in including gender issues and perspectives in the conversation and solutions about decolonizing global health. We examined mistakes that we have made in global health that need to be addressed as we work to decolonize the sector. Two of our expert panelists touched on the importance for donor countries to understand and adapt to indigenous cultural contexts instead of using a Western lens for development. One of our experts helped us debunk the premise within global health circles that developing countries do not have the solutions to health problems, that they have internal solutions that need to be listened to. We insisted that country leadership should be co-creators of their programs. Finally, we call for the full participation of women and youth in the movement to decolonize global health. I thank the panel and the audience. May I invite the participants to the Betsy Kelso Center for closing remarks and lunch. Thank you.